Dear Professor, my dear colleagues, I'm honored to be here with you today. First, I'd like to thank the organizing committee for giving me this opportunity to be with you. Professor Maher Hassan, I thank you for your invitation, kind invitation. I'm going today to talk about inverted T therapeutic mammoplasty and how to choose our pedicle. As we all know that there is some criteria to choose oncoplastic breast surgery. By time, I'm changing my behavior. So from time to time, you start to do some sophisticated techniques. And when you grow up, you choose how you plan your how to manage your patient according to an algorithm. So the first question is to ask myself, can the cancer be removed with a simple wide local excision and got cosmetic results? If yes, please don't do a lot of techniques or sophisticated techniques. And if the answer is no, I ask my
صوت يا شباب.
the other question. Would an oncoplastic كده كويس? Would an oncoplastic breast surgery from the start or after neoadjuvant chemotherapy reduce the risk of positive margins requiring a subsequent mastectomy? And the other question is, are the chances of achieving clear margins so small that breast conservative surgery might not be advisable? All these questions must be put in mind to choose which technique to start with. The term of therapeutic mammoplasty was used first in 2005 by Douglas Macmillan and Stephen McCallie from Nottingham, as they used the different aesthetic mammoplasty techniques in removal tumors. So they called it the therapeutic mammoplasty. And this technique is used for patients who are suitable for breast conservative surgery, but would get a poor cosmetic outcome due to either the percentage of breast tissue size or the position of the tumor, or for those patients with macromastia and orthotic breast that would obtain advantage for improved quality of life issues relating to reduction mammoplasty and reduced morbidity that is inherent after giving radiotherapy to such patients. This is the technique where you draw your, after your drawings, after closure. This is what would happen, that you have an inverted T, the shape of inverted T. How we draw this? First, مش شغال البوينتر مش شغال وعايز ممكن نرجع بس 2 سلايد ده مش شغال هتك على ده ولا هنا طيب ماشي. This is the shape after we close. This is the inverted T. Then the first thing is that we draw the breast meridian, which is the line from the mid-clavicular point towards the nipple, and then we extend the line on the anterior abdominal wall. Then we decide where is the new nipple areola complex. So the best way that to put your fingers in the inframammary fold. Then we draw what's called the breast, the 2 pillars of the breast by moving the breast from the right to the and to the left. And finally, we should decide our pedicle according to the position of the tumor. So either we use the pedicle to fill the cavity of the tumor excised, or design our drawings that we remove the designed area that containing the tumor. This is a video for how I'm drawing this. This is the midline. Then drawing the breast median, extending from the clavicle point to the nipple. This is the top of my areola. Then we draw like a dome of the mosque. You can measure the point from the mid suprasternal notch to the top of the areola. I usually make it 21 to 23. Another way to determine the position of the nipple, that we divide the arm into 2/3 and 1/3. Another way is to put your measurement tape in the inframammary fold, and then you find it in the same position. We extend the breast meridian over the anterior abdominal wall. Then we pull the breast to medially and laterally to draw our pillars. It is different according to the skin elasticity from patient to another. You can make it from 5 to 7. I usually put it shorter because I start closing from outside to inside. So by the end, this makes more projection to the patient. Then we draw the our inframammary fold. Then we join the 2 points to make the ghost area. In this patient, the tumor is located in the lower inner quadrant of the breast. So I'm going to decide which pedicle to use. You can use superior, lateral, inferior, but in this case I use lateral because I was worried about the margins. So I keep my pedicle away from the area, then so I can get the whole. So I decided to do a lateral pedicle for this patient. I get 2 benefits: that the tumor is located in the traditional excised area, so I can get more margin if needed. The other thing, that I'm going to use the pedicle to fill all the cavity created after tumor excision. So who needs an inverted T therapeutic mammoplasty? This depends according to the excision volume. As you know, more than 20% excision of the tumor needs mammoplasty techniques or level 2 mammoplasty techniques, according also to the tumor location and according to glandular density. The glandular density determines how is the blood supply of the breast. The more the density of the breast, the more you can go for mobilization, even though mobilization from the prepectoral fascia and from the skin. The more fatty the breast, you need a definite blood supply, so you go for more therapeutic mammoplasty techniques. How I choose my pedicle, as I'm starting, it's well known that there is different pedicles. The most common usually is the superior pedicle, the inferior, the medial, or the superior medial, and the lateral pedicles. As I said, I have an algorithm in my brain, so I can choose which technique I start with. For an example, these upper polar lesions, when you remove without filling the cavity, that will end with upper polar deformity. So in this technique, it's wise that I can use the inferior pedicle therapeutic mammoplasty. So I use the pedicle to fill the cavity, like this patient. As you show here, the pedicle, I remove the tumor first, and send it to, if available, a frozen section. After getting a free margins, then I remove all the excess tissue. So as you see here, I use the pedicle to fill the cavity. So by the end, you can get a normal contour and shape of the breast. So the pedicle here is filling the cavity. You can modify your pedicle according to the location of the tumor also. For an example, for this lower polar lesions, this what ends was the bird's beak deformity of the lower pool. We can use the reverse, that you are using a superior pedicle therapeutic mammoplasty. So the tumor here is located in the traditional excised area. So all what you need, that you are going for a mammoplasty technique, very simple, and just removing the tumor, the area designed to be removed, including the tumor with the safety margin. Like this patient was, I used a superior medial inverted T therapeutic mammoplasty. She had a multi-site tumor. So all the lower half of the breast was removed and excised. For some patients, for the old patient with high morbidity, all what you need is just to keep a normal shape of the breast and the contour. So in this patient, I removed the nipple areola, including the tumor, including the nipple areola complex, and make it more simple. Just the patient wants a breast mount that can wear her breast. Amazingly, that patient was happy with the new breast better than the old one, the other one. So as we said, you can choose from the which pedicle according to the tumor location and which one you use. But you should ensure that the nipple area complex vascularization as well. If you can keep the nipple sensation better, increase the blood supply, so you use more than one pedicle. You should avoid pedicle kinking and pedicle rotation. So can we have another way for improving the breast vascularity? That we are using the breast septum, which was described by Mustafa Hamdi in 2002, that it is like a mesentery of the breast that carrying with it the blood supply and the nerve supply. And in this patient, this is a lateral pedicle with septum-based blood supply. So this is a dual blood supply, improving the blood supply. What's important, and what we notice, that it is improves the sensation of the breast. This is another case, as you see here, the blood supply coming from the first and fifth intercostal spaces, going to the nipple areola complex, including, of course, with it, the nerve supply to the nipple. In this case, this is a superior medial pedicle. The best way how to learn how to know the exact site of your breast during your mastectomy is that you start from raising the flaps, and then you withdraw the breast towards down, and with a swab, just keep it on at the prepectoral fascia plane till you see exactly where is located the vascular pedicle coming from the fourth and the fifth intercostal space, and then you will be adapted to find it and learn how to preserve it. By the septum-based mammoplasty may improve the vascularization of the nipple area complex, the shape of the breast, and we sure that the patient, we preserve the septum with them, have a better sensitivity to the nipple areola complex. Thank you.
شكرا دكتور أيمن.
Thank you, Professor Abu Shmila, for this very sensitive presentation. Thank you. Next speaker.
May I present Dr. Alaa El-Sisi. He'll present a video for combined dermal sling and pectoral fascia for implant covering after simple.
Bismillah ar-Rahman ar-Rahim. At first, I would like to thank the chairman and the organizing committee for this nice conference. I would like to introduce a combined dermal sling and pectoral fascia for complete covering prepectoral implant. الامبلانت covering سواء either in natural way or biological or mesh synthetic material. الكفرنج بتاع الامبلانت هو كان دايما العامل المغير او الاليمنت اللي بيفرق معانا في سواء كنت هتحط بريبكتورال او سبكتورال. سبكتورال implants has many drawbacks and the prepectoral introduced now is the first in management. We challenging in 3 ways. A large totic breast prepectoral implant we use dermal sling only. In moderate size we use extended dermal sling, but the challenge more in small and medium sized breast. The pectoral fascia is attached to the clavicle and the sternum and cover the pectoralis major muscle. The pectoral fascia extended laterally to be continuous with the fascia of the back. Some anatomy about the pectoral fascia. The second question, is the fascia vascularized? It is essentially vascularized. But البوينتس المهمة, it is richly innervated with sensory receptor so that excision of the pectoral fascia introduce mini pain after سواء modified radical mastectomy without pectoral fascia preservation. Pectoral fascia preservation has many advantages, reducing pain and seroma even, and so it is not invaded. Routinely, is pectoral fascia removed in modified radical mastectomy. There is no evidence that the routine is not justified. Only in cases where it's invaded or the margin not satisfied, we can resect a small part or even the pectoral fascia and the preservation if it is not invaded. What is the space between the breast and the pectoral fascia? There is a layer of loose connective tissue between the breast and the pectoral fascia known as the retromammary space. It is a very, very important space for preservation of the pectoral fascia and excision completely of the breast tissue. The dilemma of prepectoral and subpectoral fascia implant present. In recent years, breast implants have been frequently placed in the subcutaneous pockets, the prepectoral approach. The recent covering as ADM and the meshes improves the prepectoral approach. We introduce a natural covering for the implant in prepectoral region. وقلنا عملنا تشالنج في الكومبليت كفرنج في اللارج بريست او التوتيك بريست by dermal sling or extended dermal sling في moderate size with moderate sized breast, and now we برضه natural covering of the implant with a small and medium sized breast by 2 covering. Firstly, steps as any steps, wise pattern demarcation, dermal sling, epithelialization of the lower dermal sling, glandular resection, dermal sling inferiorly, pockets for pectoral fascia, combined technique, dermal sling and pectoral fascia elevation, covering pectoral fascia, covering more or half of the implant, and we cover another covering by the dermal sling. Even sometimes we can elevate the pectoral fascia, do complete covering of the implant, and the second layer is the dermal sling. Sometimes in small breast we have and the half pectoral fascia and the dermal sling for covering. After covering the implant completely, second layer of skin covering and nipple area grafting, nipple grafting, tie over after grafting. In small breast also we can preserve the nipple as no long subway for vascularity. We can preserve the nipple, especially in a small breast as this case. Sometimes bilateral implant in bilateral tumor and extending, we can do breast implant and covering by the same technique. Post-operative cases after the first dressing, right case or left case of complete covering the implant by pectoral fascia and dermal sling. after healing of the graft and the breast size, after radiotherapy. This video هنبدأ الستبس. ممكن نشغل الفيديو بس. نشغل الفيديو بس. الآخر سلايد. اللي قبل الأخيرة.
لو محطوط بره بالفيريفيكيشن شغالين بره بالفيريفيكيشن.
اشتغل كده. The first step is depixelization. As we know, depixelization, especially from the right side, the lower adherent part of the skin, mostly at the inferior depth, different technique for depixelization, but I know the most important point after complete depixelization, we got hemostatic of the point after complete depixelization للبليدنج point. After complete depixelization, the advantage of the wise pattern في الجلاندولار resection, it is very so easy and rapid. Excision of the glandular pattern from wide incision. البلو داي for sentinel lymph node identification. الكالر. اللور ديرمال سلينج. في الجلاندولار ريسكشن to reach the sub-mammary space أو retro-mammary space, we should grasping the breast upward and tightly to introduce this fascia. And low current diathermy to spare some of fatty tissue above the pectoral fascia. So easy to do glandular resection from wide incision. Picture of glandular resection. Sentinel lymph node. Pectoral fascia elevation, the most important point, low current of diathermy or by sharp dissection by scissors, or sometimes with saline injection in the subdermal, in the submammary space. Elevation of pectoral fascia pockets, so easy. After elevation of pectoral fascia, as we see implant, sometimes good elevation of the pectoral fascia can completely cover the implant. Sometimes we double covering by the implant and the dermal sling. In short cases, يبقى half and half من dermal fascia and combined dermal sling. Fixation of the implant by suture, not completely natural covering. as we see. Complete covering of the implant with natural tissues. Second layer of the dermal sling to another covering. Or sometimes half and half covering, especially maybe the upper part by pectoral fascia only. Injection في الاريا of axilla for relief of pain post operative. Very marked efficient for relieving of pain post operative after complete covering the implant by natural tissues. Two drains, one the axilla and the other under the implant. Yes. من good point, complete hemostatic control للديرمال سلينج للبوكتس اوف بلاد عشان to avoid our blood collection underneath. This case with aerial preservation, not grafting, and another case we do grafting nipple to centralize the breast tissue. But in a small breast we can do without grafting, as the flap is very short. After completing the procedure, thank you.
Thank you, دكتور علاء. تمام. may I present Professor Dr. Shrif Taha, Assistant Professor in National Cancer Institute. He will give us a presentation with the title of LD flap reconstructions. Dr. Shrif, تفضل.
Good afternoon. I'll speak today about maybe the oldest technique ever for breast reconstruction by an extended LD flap. Really, each year we insist, we always have the LD flap in our talks to demonstrate how important this method of reconstruction, although what is being propagated these days about that it's on the decline, that it is not, it carries a lot of morbidity. However, it is really the oldest technique ever for breast reconstruction from back to 1896. However, till now, it is the most reliable method of breast reconstruction, and it's really the workhorse of reconstruction despite the numerous other techniques that are present. Raising an LD flap really depends on good knowledge about the anatomy of the muscles of the back. I'll not go into much details here. However, you'll try to dissect the muscle from its natural origins and to dissect it from its lumbar fascia, the trapezius, the external obliques here, and to raise it in, over its tendon and rotate it to the front. Of course, as we all know, blood supply is by the thoracodorsal pedicle and other blood supply from the lumbar vessels. This is the diagram demonstrating the different skin paddle techniques that had been demonstrated in the LD flap reconstruction. Not all are used for breast reconstruction. We all know how versatile and reliable this flap is, and it's used in a number of techniques of reconstruction all over the body, like the head and neck, breast, and even for free flaps. However, if we can see, this type of skin paddle is usually used in the free flaps and in breast. They all have a common origin from here. This demonstrates how much the blood supply is, or the perforators of the LD flap are accumulated in this area. So most of the flap designs try to incorporate this area within the resection, within the skin paddle. Our case is a 54 years old female. She has a multicentric invasive lobular carcinoma, T2 and 0. She's an average body weight, BMI of 26, and only morbidity is she's a smoker. She has slight asymmetry between the left breast where the cancer is. Here is the main tumor is here. And this breast is slightly elevated than the other side. First, the diagram of, we try to incorporate a large skin paddle to accumulate most of the fat in the skin paddle, and to allow good closure with minimal morbidity to the back. Other lines include the scapula, here, the midline, the iliac crests downwards. In the front, we have the footprint of the breast, the meridians, and midline. We usually use electrocock 3. We don't use tumescent fluid or sharp dissection. We sometimes do frozen section from the back of the nipple. Here's a video. I tried jamming 3.5 or 4 hour operation into a 10-minute video, so it will be a little fast forwarded. Here you can see we utilized an infralateral incision, for which we have done the mastectomy. We can see here the mastectomy flaps. Try to preserve as much as possible the perforators. Here's the footprint of the breast. Mastectomy is still connected through the axillary tail. First step is we try to prime the tendon of the LD and elevate some of the LD from the back in order to facilitate resection. Here the patient is in back, her head is cranially is like this, caudally is downward. Sorry, cranially is after. We try to dissect the LD from the skin and subcutaneous fascia. We usually try to preserve as much as possible the deep fascia of the back. We take as much fat as possible, however, we don't try to breach the deep fascia. We try to preserve it as much as possible. So you can see it glistening here. The section, when you breach the deep fascia of the back, this calls for a lot of complications and causes a lot of morbidity to the back. Here, medial dissection, try to show the trapezius muscle, and lateral dissection to open the tunnel between the back and the axilla. We continue in this plane, preserving as much fat over the LD as possible. This plane is really avascular. You can use one towel throughout this operation. Again, sorry for the jerky movements because of the fast forwarding. Here we dissect the lower part of the flaps, still in the same plane, preserving as much as possible and taking as much extended fat as possible from the back without breaching the fascia. Here's the fascia. Here's the iliac crest. You can clearly see the difference between the fat of the back and the fat of gluteal region. Then from the lateral side, we try to dissect the LD from the underlying serratus muscle. Here, you try to preserve as much as possible the serratus fascia covering the serratus because of the serratus branch running, serratus branch of thoracodorsal arteries that is running under this fascia. So preservation of the fascia of the serratus here is important to protect here the underlying vessel. This vessel can be used as a landmark to the thoracodorsal pedicle later on. Here lumbar perforators are ligated and secured. Continuing this section downward over the thoracolumbar fascia till we reach the lower part of the flap. Then the flap is rotated medially and dissected from its origin from the iliac crest and rotated upwards towards the breast. Here's a medial dissection from trapezius muscle. Also, due to the very high blood supply of the trapezius, care must be taken here from the small vessels running to the trapezius. The section is carried cranially till reaching rhomboid measure. Again, lumbar perforators are ligated. Subscapular fat, part of it can be taken and raised with the LD. Here you can see the rhomboid. Here. Parascapular fat and the fat covering the medial part can be raised safely with the LD through the circumflex branch of thoracodorsal artery. The section then continues cranially. Here I think you can see the section over the tendon of the LD in order to slim it as much as possible in order to be passed to the front. Here the pedicle is dissected. Again, the landmark is the serratus branch, which we can see here. I think you can see. Then the LD is tunneled to the front. Fascia of the back is closed over suction sutures. Here, cranially is upwards, caudally is downwards, and the tendon of the LD is dissected. I usually cut the whole tendon. I used to cut the nerve, however, these days I don't cut the nerve because this increases the atrophy of the muscle. However, I cut the tendon completely. Deepsalization is done. After complete deepsalization, hemostasis is ensured. Patient is brought into a sitting position. And then the LD insetting is done. Here I'm trying to inset, however, I try to close first the lateral part of this section. This should not have been opened from the first part. You must ensure a good pocket. To avoid migration of the LD back to the back. Here the patient is brought into a sitting position and the LD is fixed to pectoralis muscle. We try to inset it as much as possible as a normal breast, with using the skin flaps and most of fat in the lower quadrants. Then we trim the edges. And we close it all up. Here is the post-operative view of the patient. There's the section, the nipple margin, and the sentinel lymph nodes removed. Intraoperative view. And the final biopsy pathology as a multicentric invasive lobular. Deep margin is negative, sentinel negative, extra margin over the upper inner part was free, and extra margin from the nipple was free. Here's after 3 weeks, after removal of the drains, post-operative view, lateral views, 3 weeks post-operatively, and about 2 months post-operatively. And the pre-operative and post-operative look nearly identical. Thank you.
Because of the paucity of the microvascular surgeon and the cost of the implant. So the question will be at the end of the session. Thanks again. The questions will be at the end of the session.
Okay.
So thank you again. It's my pleasure now to introduce Dr. Omar Morsi, and he will talk about lipofilling and breast reconstruction.
Pointer. Red spot. The next topic.
The next the pointer. Good afternoon. Today I'll be presenting the video presentation on lipofilling and breast reconstruction. Before I start, I would like to thank Dr. Maher, Head of Surgery Department at Bahia. As Dr. Maher introduced lipofilling at Bahia, and personally by working closely with him, I have learned this procedure and I believe that it is a very important tool for every breast surgeon to have who regularly performs breast reconstruction. Autologous fat transfer has assumed an important position in breast surgery as a means for correcting asymmetries and contour irregularities and augmenting soft tissues. The origin goes back to 1893 when the German surgeon Gustav Nuber transplanted adipose tissue from the arm to the orbit to correct the breast scar as a sequelae of osteomyelitis. It was applied to the breast in 1895 when Czerny attempted to transfer a lipoma to the chest for breast reconstruction. Concerns regarding the safety of fat grafting in the setting of cancer recurrence and surveillance limited its application in the breast until a 2007 paper by Coleman and Sabero demonstrated its long-term safety in 17 patients. Today, fat grafting is being used frequently in both implant-based and autologous reconstruction. Small volume transfers are helpful during revision to correct contour defects, such as step-offs at the junction of the flap and the chest wall. Two recent systematic reviews and meta-analysis of the literature in 2022 showed the oncological safety of fat grafting in breast after treatment of breast cancer, with no increased loco-regional recurrence rates. However, there are some limitations. The potential risk of developing microcalcifications or palpable breast lumps caused by fat necrosis, both of which could confuse physicians of a possible recurrence, has delayed the use of fat grafting to correct breast contour defects. Also, the results of lipofilling have been seen as unpredictable. Sometimes after a lipofilling procedure, partial resorption of the grafted fat would occur. Previous authors have reported a 40 to 60% clinical volume loss, usually within the first 4 to 6 months. A volumetric study measuring the amount of fat resorption after fat grafting in reconstructed breasts with an LD flap showed a resorption rate of 21%. However, more recent papers have shown that these problems might be of less significance than previously believed. Several publications have reported good outcomes and patient satisfaction following the correction of contour defects with lipofilling. Fat transplantation can also be used to fill atrophic scars and reduce scar contracture as an alternative to other surgical techniques. Now I'll present this video. He's a 42-year-old patient who had already underwent left nipple sparing mastectomy for DCIS. She has an upper-outer quadrant deformity. These are the cannulas that are used for lipofilling. Here, we make a small stab incision in order to inject our tumescent. We inject saline to epinephrine ratio to 1,000 to 1 using the multiple hold irrigation cannula over the donor area, which is done by post-operative markings. Here, we only inject the abdomen. This is our donor area for the fat aspiration. The aspiration motion is a sweeping motion in order to break the fat. And here, the left hand should always feel the tip of the cannula in order not to breach the rectus muscle into the abdomen. We usually aim to achieve a wet technique, which is a 1-to-1 ratio of the injected tumescent and the aspirated fat. The procedure success starts with the injection of the tumescent. It's important to equally distribute the tumescent over all the donor area. Here now we begin the aspiration. We use a 3mm harvesting Coleman cannula. And here you see the golden yellow fat. When you see the fat coming out golden yellow, you know that you have properly injected the tumescent accurately, and you're going to end up with good amount of fat that you will inject in your defect. Here, the fat was left for 15 minutes to decant, and now here you can see the separation of the fluid content. After 15 minutes, all the fat separates from the fluid. And here, we sometimes need to do a processing of the fat in this three-way cannula in order to break down the fat. Sometimes the fat is too big to inject in the injection 2mm cannula. As you can see here now, we inject the fat in thin lines. We cannot inject the whole fat globules in one push. We have to introduce it in thin lines in order to the fat graft to take well in the breast. Here we inject in the LD flap and we inject subcutaneously as well. As you can see here, the insertion of the injection cannula, we break down with it the fibrous adhesions in order to homogeneously distribute the fat all over. This is a very important step to break the adhesions that are present from the previous surgery. And always inject in thin lines. Usually we aim to achieve a correction of 10 to 15% overcorrection. As I have mentioned previously, there is a rate of fat resorption, so you aim to overcorrect in order to counteract this resorption. As you can see here, we different stabbed incisions in order to access all the planes of the breast, because we need to inject the fat in multiple different planes. Okay, this is the preoperative photo. And this is 1 week after the injection. And here, this is a 6 months post-operative photo. Here you can see, of course, that there was some rate of resorption. However, it has been sufficient and the patient is very well satisfied with it. Here's another case that underwent left skin-sparing mastectomy and LD flap reconstruction, and in another session we had the fat grafting and nipple reconstruction on the ipsilateral side with breast reduction on the contralateral side. This is another picture of a patient who had right skin-sparing mastectomy and LD flap. This is only, all the cases I presented only had 1 session. This patient with only 1 session of lipofilling. As you can see, the upper pole, as you can see, the upper pole defect, the pointer isn't working, the upper pole defect has been completely obliterated with 1 session of fat grafting. To conclude, I'd like to say that autologous fat grafting is a useful and reasonably safe option for refinement of post-mastectomy breast reconstruction. The procedure is technically straightforward and is associated with a very low rate of complication. However, it is important that physicians and patients should be aware that resulting fat necrosis or oil cyst formation in a limited number of cases, but it sometimes may be confusing clinically and may require additional breast biopsies. Thank you.
Thank you, Dr. Omar Morsi. And now it is a pleasure to introduce Professor Imad Hamid for a lecture, Extended Thoracodorsal Artery Perforator Flap, Extended TDAB for Total Breast Reconstruction in Small and Medium-Sized Breasts.
Assalamu alaikum. At first, I owe a great thank you to Dr. Maher Hassan for giving me this opportunity to highlight my presentation, Extended TDAB in Total Breast Reconstruction. So, what is the new? In the previous session, my colleagues highlighted TDAB or chest wall perforator flaps in partial breast reconstruction. The story started by Rance Perry, who was the father of LD breast reconstruction in the modern era and changed his beliefs in partial breast reconstruction from the use of mini LD flap in partial breast reconstruction. So he changed his beliefs and shifted by introduction of chest wall perforator flaps by Mustafa Hamdi in 1992. The recent advances is introduced by the third one, who is Claudio Angrigiani in 2010, as he introduced total breast reconstruction using extended TDAB flap. So this anatomical covering is covered by my colleagues, the chest wall perforator flaps and the blood supply of the chest wall, and this is the skin island underlying latissimus intercostal. This is LI cap, and the first one is the TDAP, second one LI cap, and this is muscle sparing type 1, type 2, and type 3 latissimus dorsi flap. TDAP flap. The related or pertinent anatomy is highlighted in details by Professor Dr. Walid al-Nahas. And this is the illustration for partial breast reconstruction. So what is the new? Claudio and Grigiani introduced the extended TDAP flap breast reconstruction. What is the new? The design of the skin paddle is extended to harvest the scapular and the lumbar fat, as if you are doing conventional latissimus dorsi flap. But he extends the harvest in the upper part to include the parascapular fat and the lower part to include the lumbar fat. And you do a skin bench test, you can reach 47 centimeter in length, and the width is 10 centimeters, up to 10 centimeters. So this video will summarize the story. Our patient is a 30 years old lady with multicentric breast cancer and finished her neoadjuvant chemotherapy. Her breast is non-toothed, cup A breast size. I decided to go for nipple-sparing mastectomy using tumescent fluid, and I injected blue dye, and the retroareolar tumor in face is retrieved and sent for frozen section. We used tumescent fluid infiltration in such cup size, and I preferred sharp dissection using a scissor, and my assistant avoids the use in the beginning the use of retractors till reaching the prepectoral fascia, and continue either sharp dissection using a scissor, or you can use a knife or monopolar diather. So this is the prepectoral fascia, and the first phase of the operation is to retrieve the mastectomy specimen using sharp dissection. And after the result of frozen section, I decided to finish specimen retrieval, and there is no auxiliary dissection. And this is the pocket, the mastectomy pocket. I spare the nipple and the areola. The first step, I am starting while the patient supine, starting to incise and starting to harvest my flap by just doing this incision, putting a towel in the mastectomy side, then in the lateral position, I start flap harvest. The first step is to do deepithelialization, cutting the skin into strips to facilitate the mission, and according to your preference, using hydrodissection using tumescent fluid, or a cutting mode of diathermy, or sharp dissection using a scissor, whatever the method you prefer. Then I start to harvest my flap after deepithelialization, starting from upside down, from medial to lateral, as I harvest the conventional latissimus, to include more and more parascapular fat. And this muscle, the previous one is the trapezius. Now I shift to the lower incision to incorporate more of the lumbar fat. Continue to harvest. And this is this muscle سوري نشغل فيديو تاني لو سمحت. مشيه شويه كمان كمان كمان. ها مش للنص قوي. ها تمام تمام. نعلي الصوت بقى. Then starting to harvest and separate the fasciocutaneous flap from the latissimus dorsi using a monopolar diathermy till reaching the site of the perforators using the Doppler. الصوت بس يعني شوية. To emphasize, I can hear the blood flow through the perforators, and I can skeletonize these two perforators on acetone, as you should. In this type of flap, extended TDAP flap, I must skeletonize the perforator. This is the Doppler blood flow, ensuring the flap is pulsatile and the perforator still intact. I decided in this case to do muscle sparing TDAP flap. And as I said, you have to bisect the muscle to reach the vertical branch of the thoracodorsal vessels. You can see the pulsation. You can see the pulsation, and my decision was to cut the muscle and do muscle sparing extended TDAP flap. The perforator in this type, you decided either a propeller flap, either flip over technique, but in this type of flap extended, you must skeletonize the perforator to gain more length and to gain more access to reach a complete breast reconstruction, not partial breast reconstruction. Again, using a monopolar diathermy is prohibited, and I use sharp dissection and bipolar diathermy. Then I ligate distally the thoracodorsal and taking a cuff of muscle around the perforators to reach the thoracodorsal vessels. We spare the thoracodorsal nerve to supply the muscle. Again, the key of success for such cases is the selection, and this is lengthy pedicle to reconstruct the breast. And I let a box of skin to be de-epithelialized at the end of the operation to ensure the vascularity of my flap. So de-epithelialize by cutting the diathermy, and this is the flap with the cuff of muscle around the perforator, and you harvest more and more fat, more and more fasciocutaneous flap. Using this cuff of muscle, you can do extended TDAP flap, and this is the rest of muscle. And now we finished the harvest of our flap and doing undermining for the donor site to ensure tension-free closure of the donor site. Then we put a drain whatever suction drain or the usual drain without suction, and we close the donor side by interrupted vicryl sutures and close the skin by subcuticular stitches. The only disadvantage of this technique is the long scar, but it will fade by time. Again, finishing the closure of the donor side and putting a derma bond on the donor side skin, and then the patient lied on supine position, and this is the flap with very good bleeding, ensuring the vascularity of the flap, as you can see. And we will deliver the harvested flap in the mastectomy pocket and trying to simulate the normal breast mold. The patient is placed in 45-degree to ensure symmetry, and we take a stitch on the medial and the superior part to fix my flap. As you can see in the prepectoral fascia, and the flap is fixed medially and superiorly using interrupted vicryl sutures. Then after finishing, you close the mastectomy pocket by interrupted vicryl sutures. And I put a drain under the flap, and the skin is closed by 40 stitches. This is the immediate intraoperative photo of our patient after successful, and this is the post-operative view of the patient with very good aesthetic outcome, and as you can see, no shoulder movement affection, and this is the post-operative photo. Another case, we select cup A or cup B with minimally toothed breast. This is a pre-operative and post-operative photo. And this is another case. I decided to do skin reducing and sacrificing the nipple areola complex. Lastly, my home message in oncoplasty: selection is the key of success. Always selection of the key of success, as our economic issue, breast-based implant reconstruction, not available for all patients. This type of patient, we can introduce autologous flaps and perforator flaps for such a patient, but cup A and the cup B. Thank you.
Thanks to Professor Dr. Ahmed Hamid for his comprehensive lecture. And now with Professor Dr. Yasser Hamid and his lecture about laparoscopic assist mini LED flap and breast reconstruction.
Today I will speak about endoscopic harvested LED flap with fat grafting for breast reconstruction. Latissimus dorsi flap is one of the most popular methods for breast reconstruction after skin sparing mastectomy. يمكن الدكتور شريف شرح البرزنتيشن بتاعت ال دي بالتكنيك بتاعها ان ديتيلز. معظمنا از Oncoplastic بريست سيرجن بيستخدم ال دي فلاب، يمكن احنا بنسميها از فريند اوف Oncoplastic سيرجن. تكنيك سهل، ايزي اديكابل، مشاكله قليله، لكن اكتر مشكله في التكنيك ده حاجتين: الدونر سايت سكار، يعني الجرح اللي في ظهر العيان اللي بيعملوا مشاكل كتير جدا، والسمول فوليوم اوف ذا ماسل. السمول فوليوم اوف ذا ماسل دوت يمكن ناس كتير قوي كانت بتعمل اكستند ال دي، ومعانا بروفيسور عادل بنور من اوائل الناس اللي شرحوا لنا الاكستند ال دي، انك تعمل هارفستنج لمعظم السبكوتينيوس بتاع الباك مع ال دي ماسل، لكن كانت مشكلتها ان هي بتعمل سيروما وبتعمل ديفورميتي في الباك، فالدروباك بتاعتها كانت كتير. فهو ده اللي خلانا نفكر في ان احنا نزود الفوليوم. يمكن الدكتور زميلنا اللي شرح اللايبوفيلنج والانديكيشن بتاعتها وعمل لايبوفيلنج في حاله كانت عامله ال دي قبل كده عشان يزود الفوليوم، احنا قلنا هنعمل الموضوع دوت immediate مع ال دي ماسل، ونشرنا دوت في البريست جورنال في 2020 اللي هو لاديسماس دورسيفلاب انهانسمنت باي لايبوفيلنج فور immediate بريست ريكونستراكشن. الفكره كلها ان احنا نقدر نعمل دبليكيت للفوليوم بتاعت ال دي ماسلز باي لايبوفيلنج، ما بيتحركش. ده السمول فيديو هيورينا اللي هو النورمال ال دي ماسلز اللي الدكتور شريف شرحها. الهارفستنج معظمنا بيعملها كويس جدا، لكن القصه كلها ان الفوليوم بتاع الماسل ذات نفسه، انت لو وزنت البريست مثلا طلع فوليوم معين، ال دي في حد ذاتها مش هتقدر تكفي الفوليوم ده. كنا بنعمل كده يا اما باكستند ال دي، يا اما كنا بنحط الامبلانت. الامبلانت ليه مشاكل، فاحنا لو عايزين نعمل كومبليت او كومبليت اوتولجاس ريكونستراكشن هنقدر نعمل اكستند ال دي او نعمل اللايبوفيلنج. اللايبوفيلنج از تكنيك از فيري ايزي، هتقدر تزود بيه الفوليوم بسهوله جدا. الفكره كلها دلوقتي انك تقدر تحقن كميات كبيره جدا من الفات من غير كومبليكيشن. ازاي؟ انت عندك وايد سيرفيس اريا اوف ذا ماسل في السبكوتينيوس، في السكين، في البيكتوراليز ماسل ذات نفسها، في السيريتس ماسل، هتقدر تحقن في دي. وفي بعض الناس بتحقن في السكين انفلوب ذات نفسه، لان احنا معظمنا عارف ان ال دي اللايبوفيلنج از انكولوجيكالي سيف وما بيزودش الانسيدنس اوف لوكال ريكارنس، فانت هتقدر تعمل وايد سبريد اوف ذا فات، فده هيقلل كل الكومبليكيشن بتاعه اللايبوفيلنج. اكتر كومبليكيشن في اللايبوفيلنج ايه؟ ان الفات ابزوربشن او ان هو يعمل اويل سيست او يعمل مايكرو كالسيفيكيشن. الفكره ان ده بتحقن كميات كبيره من الفات في حته صغيره، لكن لو عملت وايد سبريد للفات ده كله في مساحه كبيره، الكومبليكيشن هتقل كتير جدا والابزوربشن بتاع الفات هيقل كتير جدا. فبالتالي ال دي انهانسمنت باي لايبوفيلنج البنفيت بتاعتها ان هو نو نيد فور امبلانت، وان احنا بنوفر مثلا ترام فلاب از باك دور اوبشن، والكوست افكت ان احنا ما بنستعملش الامبلانت. لكن عندنا نفس المشكله، السكار الكبير اللي موجود في الباك اللي بيعمل مشاكل بالنسبه للبيشنت. فده اللي خلانا نفكر في الاندوسكوبيك ال دي، وده خلانا ننشر البيبر ديت برضو في البريست جورنال في اول 22 اللي هو combined endoscopic assisted muscle sparing latissimus dorsiflap with lipofilling. الفكره كلها ان التكنيك ده سيمبل وسيف تكنيك، الموربيديتي بتاعته قليله جدا، وهو يعني احنا ما كناش من اوائل الناس. التكنيك دوت يمكن بدا يظهر من حوالي 15 سنه، بس ما كانش بوبولار، يعني ما كانش معظم الناس بتستعمله. ليه؟ لان هو كان الناس اللي سبقونا فيه ان هم كانوا كومبليتلي بيستخدموا الات اللابروسكوب، فكان الموضوع بالنسبه لهم تايم كونسيومينج جدا. ممكن كان الميديان تايم ان هو يعمل اوبريشن من 4 ل 5 ساعات، وده بالنسبه لهم كوست افكت، فما حصلش فيه بوبولاريتي. احنا الموديفيكيشن اللي احنا عملناه في التكنيك ده ان احنا بدانا نخلي الالات اللي احنا بنستعملها معظمنا از Oncoplastic بريست سيرجن اللي هو الريتراكتورز العادي او اللايت او اليمينيتنج ريتراكتورز، ان احنا نحط عليه البورت بتاع ال 10 ملم اللابروسكوب، بحيث ان السيرجن اللي هيستعمله ويدخل الكاميرا بتاعه اللابروسكوب هيبقى عنده الفيجنز فيري كلير قدامه. تاني حاجه الالات بتاعه اللابروسكوب السباتولا والجراسبرز، احنا برضو مش فاميليال بيها، او انا عن نفسي ما بشتغلش جنرال سيرجري كتير باللابروسكوب، فاحنا بدانا نستخدم الالات بتاعتنا اللي هو اللونج بين بتاع الدايسيرمي والالات الطويله. فاحنا ده اللي خلانا ان التايم بتاعنا يبقى قليل جدا، ان احنا بنستخدم نفس التكنيكس اللي احنا بنستخدمها بموديفيكيشن بسيط. يمكن هي ديت الالات اللي احنا بنستخدمها. السكار ذات نفسه، السكار بتاع الاندسكوبيك ال دي هو فيري سمول سكار في الميد اكسيلري لاين. في بعض الزملاء وبعض الاساتذه كانوا بيستخدموا دايما الانفرولاترال انسيجن بتاع البريست، ويخش يجيب بيه الماسلز ويعمل لها هارفستنج. وزملاتنا في جامعه المنصوره نشروا كذا بيبر على الموضوع ده. بس هي قصه ان هو بيبقى فيري لونج ابروتش عشان توصل لحد الماسل وتجيبها. ففي الميد اكسيلري لاين ان ذا فرونت اوف ذا نيبل وايرولا، ده هيديك اكسس لكل الماسل، تقدر تعمل هارفستنج لمعظم الماسلز كلها من السمول انسيجن ده. وبعد كده انت هتاخد الانسيجن ده تستعمله انك تطلع منه الدرينز بتاعت الباك والدرينز بتاعت البريست. في مشكله في ال هو ده الفيديو بتاعنا على الاندسكوبيك ال دي. خلاص، دي حاله نيبل سبيرنج ماستكتومي. ما هو لو حركنا كده هجيب السلايد اللي بعدها، هي دي السلايد الوحيده اللي موجوده. عايزين فيديو شويه يعني عشان بس الوقت. طبعا يعني هنعمل نيبل سبيرنج، كل زملاتنا شرحوها، وهنعمل بريزرفيشنز للنيبل والاريا، وهناخد ريترو اريولار تيشو. ده البوزيشن بتاع البيشنت. احنا عندنا تو بوزيشن، يا اما البيشنت ينام برون يا اما ينام ديد لاترال زي ما احنا بنشتغله في ال دي العاديه. ده السمول انسيجن بتاعنا. بعد ما خلصنا طبعا العمليه بتاعتنا، اول ستيب في الانسيجن انك هتعمل اليفيشن للانتيريور بوردر بتاعه اللاتيسماس دورسي فلاب. احنا عندنا دلوقتي الاورينتيشن مختلف. يعني احنا عندنا الابر سيرفيس اوف ذا ماسل واللور سيرفيس اوف ذا ماسل. الابر سيرفيس ده اللي ماسك في السبكوتينيوس، وده هتخش بالريتراكتور زي ما احنا شايفينه كده بالمنظار، في طبعا السكشن بتاعه، وهنبدا نخش نعمل سيباريشن من السبكوتينيوس من الماسل لحد ما نوصل لحد الباك ورا. طبعا الفيلد ده بالنسبه لنا يعني، او بالنسبه لي انا كبريست سيرجن او جنرال سيرجن، هو الفيجن بتاعته في الاول كنا مستغربينها، لكن الفيجن بتاعته كويسه جدا. الكنترول اوف ذا بليدنج كنا دايما بنبقى قلقانين من البليدنج لو حصل بعيد. يعني انت لو قدامك في الحته الاول 4 او 5 سنتيمتر هتعرف تعمل كنترول ليه، لكن لو ديب ورا هيبقى صعب جدا انك تعمل كنترول. فعشان كده احنا كان بنشتغل على طول بالدايسيرمي على الكواج، بنشتغل بالراحه. اي بليدنج فيزلز ممكن نعمل له كليبنج، والفيجن بتاعتنا كانت فيري كلير مع المنظار ده. كده اول لاير شويه عشان بس الوقت يعني. طيب البوردر الثانيه بقى تحت الماسل. تحت الماسل اللاتيسماس دورسي ماسل، كل الماسل اندرلاينج ليها في لوز كونكتيف تيشو موجود. يعني الاريا دي كلها هي بتبقى سهله جدا في الديسكشن. دي ممكن تبقى بلانت او باللونج بين بتاع الدايسيرمي من غير اي مجهود. هي لوز كونكتيف تيشو، كل اللي فيه بس ان بيبقى فيه البرفوريتور بتاعه الانتركوستال ارتري انت شايفها، وقدامك انت هتقدر تعمل كنترول لكل البليدنج دي، يا اما بمايكرو كليبس او بالدايسيرمي دايت. فانت كده فصلت الماسل الابر سيرفيس واللور سيرفيس بسهوله جدا. القصه كلها او الصعوبه هتبقى انك تفصل البوستيريور بوردر من الترابيزيوس، وانك تقطع اللور بوردر، وده عن طريق برضو اللي هو الفيديو اسيستد لابروسكوب. ده هيبقى ايزي. كمان حته. طب احنا دلوقتي عملنا هارفستنج للماسلز وطلعنا الماسل لقدام. القصه كلها انا الاندسكوبيك ال دي ديت انا معايا الماسل ذات نفسها، هحقن في الاندسكوبيك ال دي هارفستد ماسل دي، وهحقن في البكتورال ميجر، وهحقن في السيريتاس، وهحقن في السكين انفلوب. هي القصه كلها ان انا بعمل كومباين بين الماسلز واللايبوفيلنج. يعني اللايبوفيلنج دوت بيساعدنا في ان هو يزود لنا الفوليوم بصوره كبيره جدا. انذر كيس، وطبعا الاندسكوبيك ال دي ما نقدرش نستخدمها غير في سمول تو مودريت سايز بريست ومينلي سمول بريست. ده الانذر بوزيشن ان انا انيم العيان ديد لاترال، وان انا اخد السكارز في الموضوع ده، وادي الماسل هارفستد من السمول انسيجن ده، وبعد كده هنقلها لقدام وازودها بالفوليوم. وده البيشنت بوست اوبرتيف، وده البيشنت بعد فتره. التيك هوم مسج ان الاندسكوبيك LED augmented by fat graft is safe, easy technique with hidden scar and high satisfaction in small and moderate sized breast. Thank you.
Thank you. Very nice presentation. We may introduce the next speaker, Professor Maher Hassan محمد عسل. بروفيسور محمد عسل هيتكلم على التريبل نيبل سبيرنج تراي فيليكال نيبل سبيرنج ماستكتومي ان لارج توتيك بريست.
مساء الخير، بسم الله الرحمن الرحيم. أول حاجة بشكر أساتذتي والحضور والزملاء، وبشكر اللجنة المنظمة، وبالأخص بالشكر الدكتور ماهر على المؤتمر اللي ما يقلش بأي حال من الأحوال عن أي مؤتمر انترناشونال، ومزيدا من التقدم إن شاء الله. التوك بتاعي النهاردة عن الترايبيديكال نيبل سبيرنج ماستكتومي. الحقيقه الايفوليوشن اوف ذا بريست كانسر سيرجري بدات من الراديكال ماستكتومي، وبعد كده حصل امبروفمنت للموديفايد راديكال، وبعد كده لما لقينا الانكولوجيكال اوتكم بتاعه الكونزرفتيف بريست سيرجري ايكويفالنت للماستكتومي، دخلنا في الايرا بتاعه الكونزرفتيف بريست سيرجري اللي هي وايد لوكال اكسجن اوف ذا تيومر وذ فري مارجنز، axillary assessment either sentinel lymph node biopsy او complete axillary clearance and post operative radiotherapy. وبعد كده بدأ يحصل انتجريشن للبلاستيك سيرجري تكنيك في الكونزرفتيف بريست سيرجري عشان يطلع منها الاونكوبلاستيك بريست سيرجري اللي further subdivided into oncoplastic volume displacement and oncoplastic volume replacement. الكونترا انديكيشن للانكوبلاستيك والكونزرفتيف بريست سيرجري like presence of the diffuse microcalcification, multicentric tumors, failure to reach negative margins. كان دايما الحل ان انت تعمل ماستكتومي، بس كان الهوب بعد كده ان احنا دخلنا في الايرا بتاعه الكونزرفتيف ماستكتومي. كونزرفتيف ماستكتومي انكلودنج نيبل سبيرنج وسكين سبيرنج ماستكتومي، ودايما الريزلت بتاعه الكونزرفتيف ماستكتومي بتبقى هاي ساتسفاكشن ريت وايزي، والكومبليكيشنز فيها اقل في الحالات السمول نون توتيك بريست. اما في اللارج توتيك بريست دايما بيبقى المشاكل بتبقى موجوده، فعلشان كده بدانا نعمل انتجريشن للريدكشن اور ماستوبيكسي باترن في اللارج توتيك بريست في اللي هي الترايبيديكال نيبل سبيرنج ماستكتومي. women with a large totic breast can result to high rate of the complications، بيوصل ل 50% من الكيسز ممكن يحصل لها نيبل نيكروزس، سكين بيلر نيكروزس، والتي جانكشن بريك داون برضه من المشاكل اللي ممكن تحصل في الحالات دي. ده منظر الكومبليكيشنز اللي بتواجهنا. التشالنجز اللي بتواجهنا في حالات النيبل سبيرنج ماستكتومي اللارج توتيك بريست including redundancy of the skin flap and extensive dead space, vascularity of the flaps and the degree of the breast ptosis. Four major parameters have to be ensured in the nipple sparing mastectomy in the large totic breast, including number one, viability of the nipple areola complex, viability of the skin pillars, and stability of the T junction and good aesthetic outcome. اول حد اتكلم عن الترايبيديكال نيبل سبيرنج في البريفنتنج ماستكتومي او في البروفيلاكتيك ماستكتومي، كان ايذر تو اوبشنز في البروفيلاكتيك ماستكتومي، ايذر ان هو تتعمل تو ستيج، يعني يتعمل الاول ريدكشن ماموبلاستي وبعد كده يتعمل عليها كونزرفتيف ماستكتومي، او جربوا الترايبيديكال، ومن هنا احنا اصلا بدانا نشتغل الشغل بتاعنا. الفكره الثانيه ان البلاد سبلاي اوف ذا نيبل بيعتمد مينلي على السبديرمال بلكسس اللي جايه من البرفوريتورز اوف ذا internal memory artery and lateral thoracic artery. Avoiding the complication by keeping intact blood supply for the nipple and the flaps, avoiding any kind of the tension on the blood supply, and avoid the T-junction breakdown by supporting it with a dermal flap. Importance of the 3 pedicle dermal flap nipple sparing mastectomy. Number 1, bridging nipple sparing mastectomy and breast reduction, ensuring blood supply of the nipple areola complex and the skin flaps, and ensuring the stability of the T-junction, correcting the position of the nipple, better breast shape, and the perfect aesthetic outcome. Steps, techniques. First of all, wise pattern technique, all of us know it. We start by drawing 3 vertical line, and first of all, the breast meridian line running from the mid-clavicular point through the nipple to the inframammary line to the mid-inguinal point. First of all, I will decide the future nipple by one of 3 methods. Number 1, anterior indentation of the inframammary line, which is called the Bittenji technique, or mid-humeral point while the patient is standing, or the point of junction between the inframammary line and the anterior axillary line. It's a transverse extension to the breast meridian. All of these are methods for determination of the future nipple. After that, we are drawing the 2 pillars either by freehand drawing or template. The length of each pillar about 8 to 11 centimeters, and the angle is variable according to the laxity of the skin, angle between the both pillars, according to the laxity of the skin, according to the site of the tumor, size of the tumor. After that, medial and lateral extension of the pillars to just 2 to 3 centimeter lateral to the midline to make the scar more hidden, and laterally I can make much more extension for the lateral incision to correct the dog ear, particularly in those with a large ptotic breast. After that, we start by de-epithelialization of the wise pattern, as you can see, and the mastectomy incision usually from the lateral side. Mastectomy, like any mastectomy, the plane, the universal plane between the breast parenchyma and subcutaneous fat. Usually, we prefer to use a combination between the hydrodissection technique, diluted adrenaline solution, and the bipolar scissor. The bipolar scissor make us controlling the thickness of the flap and avoid injury to the subdermal plexus, the blood supply to the nipple, and avoid the complications of the hydrodissection technique alone, like rebound bleeding and post-operative bleeding, as you can see. We make much more cases by the bipolar, and we are bending publication of comparison in the conservative mastectomy different types using bipolar scissor. Again, the preservation of the nipple will depend on multiple factors, preoperative factor, including clinical assessment, radiological assessment, and even MRI to exclude invasion of the terminal duct by the malignant cells, and you have to go for frozen section of the retroareolar disc. The 3 pedicle dermal flap using are superior and medial and inferior based dermal flap will provide better vascularization to the nipple areolar complex by preserving vascularity coming from the intercostal branches and the internal mammary. Here we can see the dead space after conservative mastectomy, and you have to preserve the perforators of the intercostals. T-junction point is supported by the underlying dermal flap, and the reconstruction step either autologous or using silicone implant. Actually, sometimes you prefer the autologous, better outcome, even presence of any flap necrosis or nipple necrosis. Frequent dressing will solve the problem, but the major problem if there is direct to implant reconstruction. Actually, we depend on assessment, a proper preoperative assessment of the skin flap thickness. If it is more than 2 centimeters, we can go directly, and I am sure from the blood supply and the vascularity of the skin pillars, I can go directly for direct to implant reconstruction. But if the skin flap thickness between 1 to 2 centimeters, you have to depend on intraoperative ICG, which is not available at our unit, so we can go at this step for autologous reconstruction. And then closure, like the WISE pattern used in therapeutic reduction mamoplasty, this preoperative and postoperative result of our cases. Most important, the patient selection. The inclusion criteria of our cases, presence of the grade 3 ptosis, distance between the nipple and suprasternal notch more than 23 centimeter. We have to avoid the patient should be a non-smoker, well-controlled diabetes, minimal comorbidities, and well-vascularized mastectomy flaps. Our contraindication, previous radiated breast, nipple to suprasternal notch more than 35 centimeter, gigantomastia, and those smokers. Our recommendations, nipple sparing mastectomy in the large ptotic breast is feasible up to 35 centimeter distance from the nipple to the suprasternal notch. If the distance between the nipple and suprasternal notch is more than 35 centimeter, we recommend for nipple grafting. And the tripedical breast flap, 3-pedicle dermal flap is our hope. Hydrodissection technique in collaboration with the bipolar scissor is the gold standard. And proper orientation of the vascular anatomy of the breast perforator is the key point. And the residual breast tissue in case of the conservative mastectomy is not a shame. Actually, the cases of the tripedical nipple sparing mastectomy have many complications, but the most important complication is the nipple necrosis. And if you go for nipple necrosis and the method of the reconstruction is silicone, you might face such cases, which is a fear exposed implant. We faced much more cases like that. And actually, we proceeded for a case series to use the LED flap as a salvage method for exposed implant in such situations. And the end result of using the LED flap like that, this is the end result of exposed implant, which is one of the most horrible complications for the tripedical nipple sparing mastectomy. And we published our data last February. And we conclude that the latissimus dorsi flap offer one of the safest procedures following a complicated outcome. It is an entirely autologous solution, allow patient to avoid an extended duration of the care and reducing the risk of the complication and preserve the reconstructive process. Thank you.
Now may I present Professor Maher Hassan, presenting direct to implant breast reconstruction.
Thank you very much, Dr. Ibrahim. My honor to be with you again today to present direct to implant breast reconstruction after a variety of reconstructive options regarding the oncoplastic techniques or reconstructive techniques either by perforator flaps or autologous flaps. So I will go rapidly through my presentation by historical background about the implant-based reconstruction and why we are focusing about implant-based reconstruction to put the implant prepectoral or subpectoral and the complication and its management, which is a very important point to discuss, and the conclusion. So we'll go rapidly through the history of implant that started 1895 by Vincent Czerny and transferring lipoma or fat to reconstruct the breast from the side of the patient, then started to use the glass spools or ivory or ox cartilage in 1895 to reconstruct the breast. Then the Japanese prostitutes started to use silicone injection, but they faced the problem of silicosis, and then the process improved more and more to have a polyvinyl sponge implant in 1950, then the first silicone implant in 1962 by Do Corning. So as we know, the aim of oncoplastic breast surgery is to reconstruct and maintain permanent breast contour, provide breast symmetry, and maintaining patient confidence and well-being. So the breast reconstruction have many other techniques to go with, either implant-based reconstruction or autologous reconstruction, as we see in the varieties, or implant plus autologous reconstruction, with overall reconstructive rate is getting higher, and the implant-based reconstruction is taking the upper hand over the autologous reconstruction. And in many papers, they supported this concept that the implant-based reconstruction is the most reconstructive technique performed in women with breast cancer. Is this paper published in the American Society of Plastic Surgeons 2016. Then why we prefer to use implant? Because it is a shorter and easier one-stage operation, no donor site morbidity, shorter recovery, and better outcomes with the use of the meshes, either ADMs or synthetic meshes. And the debate usually is about to put the implant either pre-pectoral or subpectoral in approach. And there are many literatures that review this, visited this point. Then we have to choose the preoperative and intraoperative points to discuss when I have to choose the pre-pectoral or post-pectoral approach, as mentioned, published in this paper about the strategies and the considerations in selecting between subpectoral or pre-pectoral reconstruction. And in general, we have to focus on a pre-operative consideration regarding immediate breast reconstruction with implants, like a pre-operative breast size and ptosis. That is a very good outcome with the moderate to small sized breast, and risky in large ptotic breast, the skin quality, and the most important points regarding the comorbidities in like diabetes, obesity, and smoking, which affected the outcome of implant-based reconstruction. And also reconstructive techniques using the direct implant breast reconstruction. And this paper focused about the volume of the implant. If it is more than 400 cc, it's very risky to have a tension and have a risk on the skin flap. And the intraoperative consideration regarding the mastectomy flap or the regarding the tension closure that will affect the outcome of the selection regarding the skin flap thickening, the bleeding edges, the lack of exposure of dermis, and maybe the use of endocyanin green to confirm the viability of the flap before putting the implant immediately pre-pectoral. So the pros and cons in the selection between the pre and subpectoral approaches, that the subpectoral approach have benefit of less capsular contracture with low risk of rippling, but it has animation deformity and more painful and indentation over the upper pore of implant and the possibility of double bubble deformity. With the pre-pectoral have the benefit of less invasive and less painful and no animation deformity, but it has a more visible rippling and the capsular contracture maybe is a higher risk. And finally, this paper concluded that pre-pectoral approach is better than the subpectoral approach. And the other narrative review concluded that although it is evident that there is still no gold standard, current literature seems to review that the choice of a pre-pectoral approach has upper hand over the subpectoral approach, as in many other publications about that support the pre-pectoral approach for implant-based reconstruction. Why? Because the breast is an organ of the skin. So it is, as in by nature, it is pre-pectoral. So you have to replace like with like. When you remove the breast, you move it from the pre-pectoral approach from the subcutaneous plane, so you reconstruct it in the same condition. And as we know that we have to use in many cases, because we have a large or to a moderate sized breast, you have to use a mechanical support to keep the implant in place. This is the use of the most important point, that we focus on the mesh. We found that the ADMs is very expensive, and we searched for many other meshes. We found that the Ultra Pro is available in Egypt, and this paper supported the Ultra Pro mesh to be safe in this procedure, and we started to use the procedure in many series, and it's our luck that we have the published and we have an acceptance of paper in the World Journal of Surgical Oncology 4 days ago, just 4 days ago. The full publication will be very soon about our experience in single stage direct implant breast reconstruction with the use of the Ultra Pro mesh. It was on about 132 breast cancer cases, and in the same approach that we will see in this video, this patient with post-neoadjuvant chemotherapy with multicentric breast cancer, and through the infralateral approach we go for nipple-sparing mastectomy and implant-based reconstruction using the silicone round smooth implant and the Ultra Pro mesh. We use the diathermy in all our cases. We don't use the scissors, or we don't use tumescent. It is a surgical preference as the surgeon prefer. And we dissect under the nipple and area complex using the cutting diathermy. There is no residual breast tissue behind the area to confirm that the safety of the patient, and we dissect in a dual plane, in the subcutaneous plane and in the prepectoral plane, so you can control the movement of the breast, and you can reach the upper and the medial part easily, so you can go for your full nipple sparing mastectomy safely. Actually, in our cases, we have 16% major complication rate with implant loss in 6% of cases only, which is comparable to the literature, which is about 15% major complication rate. As we see, we have a simple procedure that we will prepare the pocket, and then we will go to implant-based reconstruction with a very simple wrapping of the implant by mesh, and just putting the implant prepectoral in the prepectoral approach, and just taking 1 or 2 sutures to keep the implant inframedially to prevent the movement of the implant and the deformity outcome. If you have that, if you can put the implant in a pocket that can accommodate the implant without movement, you can omit the use of the mesh, because the mesh is only a mechanical support for this. This is a total nipple sparing mastectomy with axillary dissection, and the marking of it. This is a pocket with no residual breast tissue, and then we will put the implant by preparing it after complete wrapping in the anterior and posterior. The other case was sentinel lymph node, and the dye was injected periareolar, and as we see, there is no complication from the dye in the same approach. And this is the implant and the mesh, just simple wrapping of it, just putting that in, and simple stitches in the inferior and the medial parts, just to keep the implant medially, to prevent its upper or lateral displacement. And this is the final outcome, and you can go for many approaches, either by after tissue expander or after lateral approach. And now, even if with nipple sparing skin reducing, nipple sparing risk reducing surgery, you can use the same approach. But what about the complication? The most important and dangerous complication is the flap necrosis infection, capsular contracture, which is the most frequent, especially after radiation therapy, and the breast implant associated anaplastic large cell lymphoma, which is very rare. So regarding the implant related complication, as mentioned, as this paper published in 2021 about the immediate direct to implant breast reconstruction with ADM, evaluation of the complication and safety, they found that the overall complication rate is about 13%. with 6% implant loss, comparable to almost to our series. So that demonstrates that this approach is safe and accepted for patient safety regarding the complication rates. And also regarding the infection, as Krishna Clough published about the just conservative treatment of infection, as all of us know that when we have an infected implant, we go for removal of the implant, but now we can go for just conservative treatment, and antibiotic, maybe implant and pocket wash and re-implantation of the same implant again. Even the flap necrosis, we can go for conservative treatment and removing the necrotic part and just rotational skin flap to cover it. And in some cases, we can open the pocket and do a lavage, or we can remove the mesh and put the implant again as a conservative treatment to keep the implant. And the most distressing and the most frequent is the capsular contracture, which is a normal healing process in all our cases, but it is increased with the radiation therapy. And as we see in this paper published in 2021 in the American Journal of Surgery, that the complication rate, the incidence of post-mastectomy complication rate and capsular contracture, it is 7.5% if the patient does not receive post-mastectomy radiation therapy, and increased to 18% to the patient received post-operative radiation therapy. And in our series, in this case, this is a 6 months picture post-radiation therapy without capsular contracture, and we have a capsular contracture in other cases. Then we can manage surgically by capsulotomy or capsulectomy, as we will see in this video, with a case of lateral approach nipple sparing mastectomy that do nipple sparing mastectomy and implant-based reconstruction with severe capsular contracture post-radiation therapy. And we managed this case with complete with capsulotomy, and we explanted the implant and do capsulotomy and remove the large part of the mesh, and then and put the implant again in this rapid video. This is the mesh. So we get the implant outside and we do capsulotomy in all planes and take a biopsy from this capsule to roll out the anaplastic large cell lymphoma. We started laterally and we go in all planes to do capsulotomy. And some cases we go for complete capsulotomy. We remove the mesh and then remove the capsule. As we see, this is the mesh integrated totally in the subcutaneous plane. We, after just inciting it with the diathermy, there is a release of the capsular contracture. We release the capsular contracture all around the base of the breast and in a radial pattern in the flap, with immediate release in the tension and the capsular contracture. And we'll see the final results. So it is a corrective and manageable complication that you can go and does not stop you with the using of implant for implant-based reconstruction. We put a drain and we, after achieving whole capsulotomy, this is a post-operative picture, completely different from the pre-operative one that was severe capsular contracture. Another option to correct the capsular contracture is to use the fat grafting, as we mentioned in the previous presentation. And this case was a right skin sparing mastectomy in the LD flap and implant with capsular contracture, and the final picture after upper pool deformity correction with lipofilling. and the other case with the same upper ball deformity of the round implant that's corrected with lipofilling and the nipple reconstruction. So my take-home message is direct to implant breast reconstruction is a safe technique with the prepectoral approach more superior than the subpectoral approach, and the complication is manageable for this new procedure. Thank you.
Thank you very much, Professor Dr. Meher, for nice presentation and also for nice gathering of this elegant professor in yearly elegant congress. Thank you very much. For the last, we keep the best. Dr. Sharif Naguib, Professor of Surgical Oncology, National Cancer Institute. He will give us a presentation about scout radar localization. بيلقط على كام ده دكتور شريف؟ الرادار ده بيلقط على كام؟ على الأرض.
البوينتر حضرتك بتدوس عليه كده بيظهر اللايت ده تقدر تعرف ده نكست بتدوس عليها عشان تدوس نكست عايز تبقى باك تدوس عليها برضه. تمام.
Thank you very much, Professor Galal, for your nice presentation. I would like to thank the organizing committee of this fantastic Congress, and especially my brother and good friend, Professor Maher Hassan. I will be presenting a new apparatus, a new technique that we use now for guided breast surgery. It is called the Scout Radar. Why do we need guided breast surgery? Because we are facing nowadays a changing face in breast cancer. In the Western world, more than 1/2 of newly diagnosed breast cancers are smaller than 1.5 centimeters. And more than 1/3 are clinically occult, which means non-palpable. And why is that changing? Because there is an improved awareness about breast cancer among women, wide popularity of breast cancer screening program, and the increasing use of neoadjuvant chemotherapy, which might result in pathological complete response in up to 65% in HER2 positive tumors and up to 50% in triple negative breast cancer. The challenge that the surgeon faces with occult lesion is threefold. Number one, we have to find this occult lesion and localize it. Number two, we have to excise it with an adequate free margin. And number three, we have to reach or achieve an acceptable cosmetic result, which is not usually easy. There has been different methods suggested for localization. The most popular of which, and the oldest of all, the wire-guided localization, which was first introduced in 1976 by Frank et al. Others like methylene blue, like radio-guided ROL, like radioactive seed localization, like intraoperative ultrasound, carbon marking, super paramagnetic iron oxide or Sentimag, and finally, and the most recent, the Scout radar localization, which I'm going to present today. To have a look at the wire-guided localization, which was started gaining popularity in 1990, it has been the standard, gold standard of occult breast lesion excision in up to 80% of the cases for the last almost 50 years. The method is the following. The interventional radiologist introduces thin wire guided by ultrasound into the tumor, and this is done either on the same day in the morning or one day before surgery, and the patient is taken to the operating theater. The surgeon opens the skin close to the wire, follows the wire until reach the tip of the wire, and lumpectomy is done. Another method, which is radio-guided occult lesion localization, which was introduced in 2015, and which requires either a portable gamma camera or a handheld gamma probe, and where radioactive colloid is injected into the occult lesion and excised using these two apparatuses. Finally, the Scout radar system, which I'm introducing today, which consists of 3 parts. Number 1, on the right-hand side, is the reflector, which is injected in the lesion either immediately before surgery, or you can do that up to 1 year before surgery. And this radar reflector will remain in sight, will not move, and will not cause any harm to the patient until she finishes her neoadjuvant chemotherapy. Then there is the console, which generates and detects radar signal, and there is the probe or the antenna or the guide, which is linked through a cable to the console and which transmits and receives radar signals. If we compare the wire to radio-guided occult lesion localization to the Scout, I'm sorry, is the one to the right, but the clock is hiding the word Scout. We will see that the one that carries the highest number of disadvantages is the wire. Number 1, it is painful and causes patient discomfort. It is associated with the least accuracy. It doesn't allow the surgeon to choose the site of the incision because he is stuck with the point of entry of the wire, which is not always the most cosmetic place for an incision. The volume resected is the largest one of all. Cosmetic outcome is the worst of all. There is a risk of migration for the wire, and up to 25% of the time, there is a positive margin during frozen section examination. If we look at the radio-guided occult lesion localization, we will see that it has 2 main disadvantages. Number 1, there should be a nuclear medicine doctor included in the team. And number 2, we are faced with the need for nuclear handling and nuclear disposal. If we look at the new Scout radar apparatus, we will see that it does not carry any of these disadvantages, and it carries the best results regarding accuracy, choice of incision, the volume of resection, the cosmetic outcome. Nevertheless, it has only one disadvantage. It is a little expensive when compared to the wire, for example, which is the cheapest of all. This is the Scout apparatus, the console, the probe, and the reflector, which is inserted with a special delivery needle through ultrasound guidance by an interventional radiologist. We have many advantages using the Scout radar system. Number 1, when you put the probe on the surface of the skin, you have a 6 centimeter detection range, which will permit you to put your incision in the best cosmetic site, and it will measure the actual distance to the tumor or the lesion and will allow you to plan for your anterior safety margin. After you do your incision, you put the probe inside the breast tissue, and if you turn around the lesion in all directions, you will be able to predict and define safety margins all around your lesion. Finally, when you take your lesion out, you can put the probe on it ex vivo, and this will confirm the resection of the reflector, and it will also confirm adequate safety margins in all directions. Because on the console, you can see the distance between the probe and the reflector. Another advantage of the Scout radar system is that the reflector has an excellent visibility with all methods of imaging, whether mammogram, ultrasound, the specimen radiography, this is the reflector, or even in MRI. And another picture showing pre-treatment insertion. This is the needle containing the reflector, and this is the reflector after it has been inserted. And this is post-lumpectomy specimen radiography showing the reflector. Another advantage of the Scout Radar system is that it causes the minimal MRI artifact compared to Sentimag, for example. This is the Scout reflector, and this is the artifact caused by Sentimag in MRI. Now, there has been so many publications citing the advantages of the Scout Radar system. You can find them all on PubMed. Now, this is a video showing the steps for Scout Radar localization. Number one, you have to insert the radar reflector inside the lesion. This can be done up to 1 year before surgery. And then عايزين نحرك الفيديو بس لو سمحتوا. This is the first step, which is to test the probe on a card that comes with the system, just to make sure that your system is working. And you can see there is a screen on the console which shows you the distance between the probe and the reflector. It shows here 9 millimeters. Then you put it on the skin again, skin of the patient, to decide for your incision in the best cosmetic area. After incision, you can use the probe again, and you can turn around the lesion in all directions. And you have two ways to detect your reflector, either audible sound or visual. On the screen of the console, you can see the distance between the probe and the reflector. Shows 6, 7 millimeters, 9 millimeters. And you turn around the lesion with the probe in all directions to make sure that your safety margin is adequate. You continue your excision, and every time you dissect a piece of the lesion, you make sure that your reflector is inside the lesion you are taking out. This is the 5 millimeter distance, which is enough for a safety margin. So this is what we call deep localization, which is directed by audiovisual senses. Once you have dissected your lesion, you make sure that the reflector is exactly in the center using the probe again. And you can turn around the lesion in all directions. Of course, there is a learning curve for the use of this Scout Radar apparatus, and this is why it's taking so long. But probably with more experience, it will not take so much long. The lesion is almost out, and the probe confirms the presence of the reflector. And then step 6, you confirm ex vivo outside of the breast using the probe. You confirm the presence of the reflector. Now you know you have done your lumpectomy the way it should be done. And you make sure about your safety margins all around by turning the probe in all directions. Step 7, you take your sutures for specimen orientation, for frozen section examination. This is specimen orientation. And you will see that the volume of the specimen resected is probably much, much smaller than the one you will have to resect if you use wire. Because the problem with the wire is that you cannot really predict where the end of the wire is. So you always take a generous piece of tissue all around the wire to make sure you don't cut the lesion in two. And this is the reflector after it was taken out from the lumpectomy specimen. And I thank you very much for your attention.